And now we have 15 minutes for discussion. And I would request Dr. Subhanan Rai to start the discussion and take the questions. And
Thank you, Dr. Debanu. After a long time, we are meeting here, though virtually. But all the speakers, I must congratulate them because they are fantastic orators and they have given us almost update on every subject. But the index patient is lost, Nobody said what is to be done in that index patient. Gopal has tried a little bit, but nobody has cared about what the patient. Now I must ask first Dr. Malpani, who is a senior most, to talk about that patient, what you have done to stabilize him or to take him at what time, and what would be your take home on that index patient when you take the patient. You would take just a patient like that.
Dr. Roy, I think you probably meant Dr. Asfaq, who spoke on
No, Dr. Ashok Malpani is there, panelist?
No, yeah, he's a panelist, but I don't find his name here. I think.
Oh, I sorry. No, so we can start with Dr. Leela. Is he here?
Yeah, Dr.
Good
Leela.
Good morning, Dr. Rai. Tell me, I'm here.
Leela, we are meeting for after a long time, though virtually. But what you have done, to stabilize the patient, and when you will take the patient off for intervention, what would be your, take home about that patient if you find a patient like that?
I agree with what Dr. Ghosh started, that once you have to stabilize medically, and once the patient is slightly stabilized, the BPs are slightly up, then revascularization is the most important procedure. Nobody discussed the what are the blocks in the arteries. And one thing is important, we need to open all the blocks possible, not only the culprit artery, because the patient is in cardiogenic shock. So to me, the maximum number of blocks, because it has to be, usually they have multiple blocks, and we need to try to open all the blocks before we think. Now, coming with mechanical support, we have seen data that is not very encouraging. Yes, if we need to put one, we need to put before the procedure. We don't do it in the procedure or after the procedure. We need to put it before the procedure. But to me, the most important thing is the revascularization, and revascularizing all the vessels at a time, if possible, is the choice to me. And agreed with Somik that once the patient comes out, then it is important that we need to think that they are not only a candidate for restenosis or SATs, they are also a candidate that they would go ultimately in heart failure with with reduced ejection fraction, and they need to be properly managed accordingly. So to me, revascularization is the most important in this patient, and I would like to know the anatomy and open the maximum possible arteries.
Okay, that's nice to hear. Now, before going into the Asfaq for a comment, I would go to Raja. Is he there? Raja?
Yes, sir, I'm here, sir.
Yeah, Raja, would you?
Hello.
Would you add something about the mechanical support which Asfaq said?
Yes, sir. Firstly, my dear colleague Gopal, who was earlier in Apollo, has very nicely put forward the medical management part about a patient in cardiogenic shock. But we know in practical life, they do not come out only with medical management, number one. And number two, every hour the patient does not improve his BP, his treatment has to be stepped up every hour. Like what by that I mean, if his inotropes are not picking up his blood pressure, we need to immediately shift towards a mechanical circulatory support device, either in the form of IABP or, if possible, better would be an impeller. Now, there is a new concept also with impeller that first reperfuse, then revascularize. So, and that has shown to work in lot number of critical cardiogenic shock patients. So I would add that much and let the other panelists speak. So thank you.
So that is a very great point you have told already, that first stabilize or first put him on backup, circulatory backup, and then you go for revascularization. This is very important. So it has been shown that if you can put the patients on the support for an hour or so and see that what is happening, then you can go for revascularization. That will pay more benefit. That is a very important point which should be added. Number 3, Siddhartha Mani is here. I think he is also a panelist. I would ask him that do you think that there are certain other points which are necessary for follow-up of these patients, which in this particular patient is missed? What we will do extra? That you have done already you have done an intervention, and after that, what extra things you should look for in your patient? Siddhartha is there?
I don't think is there, Shivananda. There is a
So-
question in the chat box actually, which is actually the thing which we talked about, which is more important nowadays, whether it's dose to your balloon or dose to unload, which should be done first. I think there are 2 questions by 2 different persons which have come in the chat box. So I think
Yeah.
that probably merits a little bit of discussion or just to clear the
Okay,
doubts.
okay. Now I can go to the next patient. He has come after 48 hours. So we know all the guidelines say that it is 36 hours of myocardial infarction and 18 hours of shock, and the shock trial randomized the patients between 12 hours. You see, so we are slightly late. Now again, the patient is having cardiogenic shock. Here in cardiogenic shock, in a late presenter, I think dose to balloon time needs a little, backbiting. It should be on the back, but rather it should be better unload. You should go for an unload for a period of time and go ahead with revascularization. Now the point is, the one thing is missed in Gopal's lecture. That is, he has put the patient on a BiPAP. I would have gone for elective ventilation. Why? And it should be with paralyzed ventilation. Why? You know that the most of the oxygen death is due to the respiratory muscles. Once you put the patient on ventilator in a paralyzed mode, the oxygen requirement of the body is almost halved. So in these patients where oxygen is a very important thing, your DO2 is very low, there you should put the patient on ventilator, elective ventilation with a volume dependent ventilation, that is paralyzed ventilation. So the oxygen, the respiratory muscles oxygen demand is less. This is one point I should mention, that in such bad patients you should go for elective ventilation. Now the medical circulatory support. Now if so, I would ask abstract, if I give you all the supports, don't think of money. You go ahead and do everything. Everything is possible. What we will take in these patients? Will you take a IABP, an Impella, or ECMO, or combining one of them?
I think again Asfaq has left because of an emergency. So
Okay.
I think it should be Impala. If given a choice, the Impala is the best suitable mechanical circulatory support, because we have seen the IABP trials; they have never given any positive results. So I think Impala is a better choice than any other supports to me.
Why not?
Basically, yes. Why? If you look at the physiologic effects of Impala and IABP, you will see that IABP is a poor man's Impala. They have the same benefit, but in a lesser degree. If you see that the cardiac output increase, it is 2.5. If you see the unloading, it is more than 2.5 in Impella. And if you see the unloading, it is 3+. Whereas in IABP, it is 1+, 1.5, and unloading is 1+. So basically, IABP and Impella acts in a similar way, but the problem is, the catheter of Impella is 14 French. It goes through the aortic valve. There is a problem that and once you know that in such patients, if there is an acute
Sir, if I may interrupt, the physiological mechanisms of Impella and IABP are totally different, sir.
How?
IABP works with the pulsatile physiology, and Impella draws blood and then
No. The effect is same. I said if you look at the PCWP, if you look at the
Physiological.
their mechanism is different. Everybody knows
End
that.
result is basically going to be same, you know.
But the effect
And,
is on
who
effect
creates
is-
a better cardiac output is a better choice.
yeah, always. So basically,
Impella has Impella CP, which is output is
14
5,
frames.
not 2.5.
I'm coming to that. Don't worry. I'm not mistaken. I'm not demented. What I'm telling, just go and see your chart and you will find it. If you look at the afterload, it is reduced in both ways. If you see the cardiac output, it is increased in both sides. If you see the unloading, it is reduced in all places. So it is better to have Impella, which is a better thing. I admit that. But the problem is, hello? Hello?
Yeah, you're audible, Shivananda, but yeah, I think yeah, you can finish what you were saying. Okay. Okay, I think we have lost here Dr. Roy, but we also actually we have passed the time. So I would ask
I
Chandrivan.
have one point to make, a very fast point to make. Shamik, the ME trial only included diabetic patient. There were no non-diabetic patient in ME.
Yes, sir. Yes, sir. Yeah, ME only included. Impulse included both, sir.
Impulse included, but Impulse is not a
Yes, Impulse is not a
trial. It
specific-
is 3 days to 5 days is the when
1
the
to 7 days, sir. Within 1 to 7
the
days.
medicine.
Yes.
We are
Subhra,
going
there
to
is
wait
a last
for the
point.
impact result.
There is a last point. We
Impact
must,
MI result.
in this patient, we must, in the follow-up, we must take care of the kidney status because we have given a contrast. There is a high chance of contrast-induced nephropathy in such patients. And you have to, because there is a cardiogenic shock and there will be a chance of huge nephropathy and that should be taken care of. I want to add this point also.
And sir, can I just
Thank you all the respected speakers and panelists and panel moderators. So chairpersons, panelists and all the respected speakers, I truly understand that such important topics needs wider spectrum of time to discuss and do brainstorming. We will surely have some opportunities in current days very soon.